Hi, I'm Mary Ann Smith, and today we're going to talk about age-friendly healthcare and systems, focusing on mentation and the topic of delirium. So our goals for today are to overview delirium, which is also known as acute confusion, and talk a bit about why it's so important in the 4Ms. Then we'll review both screening and interventions related to delirium. I'd like to acknowledge that this program is one in a series of 8 about the 4Ms and is co-sponsored by the Somé Center for Gerontological Excellence and the Geriatric Workforce Enhancement Program at the University of Iowa Geriatric Education Center. The content is based on the age-friendly initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement. We really hope that everyone will investigate the website listed here to learn more about this very important social movement. So back to mentation, which is one of the M's in the 4Ms, and the goal is to prevent, identify, treat, and manage dementia, depression, and delirium across all settings of care. In acute care, we really do focus more on delirium, the topic today. In ambulatory care, we have a greater focus on depression and dementia. And in senior living, we really need to pay attention to all three: dementia, delirium, and depression. So why do we care about delirium? I mean, what's the big deal with acute confusion? Well, it's really high rates. There are really high rates among older adults. In fact, it's interesting. Little children and old people are at much higher risk for having delirium than people in other age groups. So in emergency departments, 10 to 30% have a delirium. Post-operatively, intensive care, nursing homes at end of life. I'm not going to read the statistics, but I think it's really important that we understand there are really high rates of acute confusion or delirium. And at the same time, that acute confusion is not often recognized. Delirium is often mistaken for dementia. Now, the two do, in fact, look alike, but this is a huge problem in acute care settings. Providers don't know what the person's baseline function is. So they kind of assume the person who is confused has dementia. And the lack of identification triggers a downward spiral. There are no interventions to treat the delirium symptoms, to reverse the underlying problem. Inappropriate medication use can persist and cause symptoms. There's failure to communicate about this acute confusion and the importance of continuing to try to reverse it at the time of discharge. And that persisting confusion, when it's left untreated, leads to greater disability and even death. So identifying delirium and distinguishing it from dementia, particularly in acute care settings, is really critically important. So the signs and symptoms of delirium, and these are out of the DSM-5 Diagnostic and Statistical Manual for Psychiatric Disorders. The key symptoms are disturbance in attention, meaning the person has a really poor ability to direct, focus, sustain, and shift attention. They also become more disoriented, and it's a rapid onset. Now, again, thinking about dementia, that's a slow, progressive onset in most cases. In delirium, it's rapid. In a matter of hours or days, the person goes from their baseline into this really disturbed, confused state where they're really not themselves in so many ways. And those symptoms tend to fluctuate in severity over the course of the day. And that makes it even more confusing for the providers. So, thinking about a fluctuating course, look at how it can go up and down over a 24-hour period. And so it's now you see it, now you don't. One provider says, "Oh my gosh, Mr. Jones is so confused." And the next shift says, "I don't know what she was talking about. He's just fine." So it's very important to share information and to assess. The other feature of delirium that again makes it so confusing is the disturbance in cognition. This is the third big piece. So attention, fluctuating course, and then cognitive disturbance or problems with thinking, including memory, orientation, language, perception, that isn't because of a dementia. Instead, it's the direct physical consequence of a medical condition or substance intoxication or withdrawal or a toxin. And the other side of it is there can be multiple causes, which is pretty common in late life. The main point here is that physical health problems trigger delirium and are often reversible, as is the acute confusion itself. We can't let it go. If it persists, it will cause more disability and for some people lead to death. So some common associated features are disturbances in sleep-wake cycles, meaning that person sleeps during the day and then is awake all night, can't get to sleep, and rapid shifts in emotion. So they go from kind of a baseline, comfortable, nice guy to screaming, cursing, muttering, and moaning, feeling anxious, depressed, irritable, angry. The other interesting piece about delirium is that the predisposing factors, the risk factors, the things that put the older person more at risk for developing an acute confusion or delirium include things like cognitive impairment or dementia. So that overlapping acute confusion on top of a more lasting cognitive decline like dementia is more common. Having multiple health conditions, which we know is so common among older adults. Sorry about that. Let's just stay focused on this slide. Being of advanced age, becoming dehydrated, being malnourished, having problems with vision and hearing, and also immobilization or mobility problems and functional decline. So on a good day, many older adults are at risk for delirium. Now let's try that next slide. So the physical causes of delirium, the actual things, not just the risk factor, but the idea that the physical cause of the delirium include things like medications, infections, and particularly urinary tract infections and respiratory infections. So the flu season is just horrendous for causing delirium in long-term care settings, and certainly for those who show up in the ED with pneumonia. Also, pain, electrolyte imbalances, metabolic disturbances, hypoxia or lack of oxygen, and sensory deficits all can cause delirium directly. And as before, delirium overlaps on top of dementia. So we can have a more stable cognitive decline and impairment that overlaps with a really rapid onset of acute confusion. So the two key actions in age-friendly health systems are to assess and then act on our findings. In delirium, we want to think about risk factors and presentation. How does the person look? How do they present? We want to think about their history for any new medication, a new onset of a medical condition that might be the trigger. And we certainly want to screen for delirium. Screening for delirium is so critically important. Again, thinking about that acute care environment and how delirium fluctuates from morning to afternoon to night, documenting our findings becomes so important. Then we'll act on our findings, treating the underlying health problem, managing symptoms that may be very disturbing to the person and supporting them to function, and certainly educating the person and the family. So in terms of assessment tips, we want to use the approach that best fits the setting and the team. So there are several options, but as we talk about them, think about what makes the best sense to your setting. Acute care, outpatient, skilled care. What are you doing? What's the most important thing for you to know and understand? We also want to adjust our approach to offering cognitive screening to avoid the sense of being tested. We talked about that a little bit in the section about dementia. So it's just another tool in the toolkit to help people stay healthy. We also want to engage and educate family members about delirium. We want to enlist their help to identify changes and think carefully about what is their baseline function. Now, in acute care settings, and again, that's a big focus for delirium, but also in skilled care settings, we want to think about what is baseline. Is the person more confused today than usual? That's often a critically important question. So in terms of options to screen for delirium, there are several listed here on the slide, and we're going to talk about each one. The point is that the scale should fit your team and your care culture. The ultra brief 2-item screener is just great and has been recently developed by a team at Penn State. Donna Fick, Sharon Inouye, and Inouye is the leader in delirium care and identification. And they've developed this very, very brief screener. Tell me the day of the week, tell me the months of the years backward, starting with December as your first month. This is a terrifically important way to get a good understanding of whether the person can pay attention to us in a short period of time. The confusion assessment method, which was again developed by Sharon Inouye, mirrors the diagnostic criteria for delirium, including the acute onset, inattention, disorganized thinking, and altered level of consciousness. So there's a lot that can be done with the confusion assessment method, and in many ways, they recommend that you can use the ultra brief screener and then follow it with the CAM. Here's an example of the CAM that comes out of the Iowa Geriatric Education Center website, which I really hope everyone will visit because there are some terrifically important materials, pocket cards, additional supportive materials about medication side effects, how to screen for acute confusion, that support the forums in so many different ways. The delirium observation scale, the third scale we'll talk about, has 13 items, and it's administered each of 3 shifts, day, evening, and night. It's even though there are 13 items, it's yes, no. So it goes very quickly and allows nurses to make a very brief and rapid determination about the person's confusion. Most are scored, yes equals 1 and no equals 0, but then items 3, 8, and 9 are reverse scored. But again, this is a very brief scale, easy to use in acute care settings, and has been investigated by another one of our investigators, Ryan Carnahan, who's an author on the article that supports this tool. There's also growing evidence for just one question. Is the person more confused today than usual? If yes, assess further. This is incredibly important in skilled and long-term care settings where we have stable caregivers providing care and oversight and assistance to older adults. It's really best used by family and direct care staff who know the person well and know what their baseline is. So in a skilled care setting or a nursing home environment, or even in assisted living, those direct care providers who know the person well will be helping the person in their daily care and say, something just isn't right. They're not on the mark. They're not themselves today. They're not doing the things that ordinarily they do quite easily. So there's the signal. We need to assess further. And again, we can circle back and use the CAM, the ultra brief, the DOS. There are lots of ways to think about how we would further assess delirium. So once we have the sense that the person does have an acute confusion, and it could be overlapping on top of their dementia or a standalone, the action piece really is guided by where we are, what's going on. Are they in the hospital? Are they in long-term care? Or are they at home? So in the hospital, we really want to think about their discharge planning and communication with other providers. If we're not able to reverse the delirium during the acute care stay, we definitely need to identify it and we need to communicate about it to anyone who is going to care for the person next, whether that's family, if they're going home, or if that's the nursing personnel in a long-term care setting. And in long-term care, there's probably a greater focus on risk factors and reoccurrence. So watching the person and carefully monitoring that if they become delirious, if they develop a urinary tract infection or a respiratory infection, they become delirious, we treat the underlying problem, they stabilize again, we want to monitor them to make sure that they don't have a reoccurrence. And at home, it's really incredibly important for family to understand what acute confusion is, that it is the direct consequence of a physical health problem. It is highly reversible if we treat that physical health problem. If it persists, we should be talking to the provider. Very important for family and persons living at home to understand what the issue is. So in thinking about how we're going to act on delirium, first and foremost, we want to know what that underlying cause is. Is it infection, pain, lack of oxygen, medication side effect? Is it some kind of an interaction between those things? But the idea is know what the underlying problem is and work to reverse it. And then second of all, we want to assure the person's safety, because as they are confused and as they misperceive their surroundings, they make mistakes that could put them at very great risk for harm. So other steps, and these are not complicated, and they're things that anybody can do. Direct care providers, nursing personnel, family members, help the person ambulate, focus on their mobility. In the hospital, we want people to sit and stand absolutely as soon as possible. And we want to support them to be safe and successful. We'll talk a little bit more about that in the module about mobility. We also want to improve their hydration. So encourage and monitor their fluid intake. A glass of water, a glass of juice, easy, accessible, within their reach and encouraged. Promote sleep without medication. And again, there's such a temptation to add one more drug to solve a behavioral problem that then ends up making the original problem persist even longer. So think about how can we help people sleep, but without using benzodiazepines or other sleep medications. And we also want to reassure the person, they may have emotional reactions. Part of the picture is that they may overreact. And it's so important to remain calm, reassuring, understanding, and orienting them as best we can to what is going on. Harvey, I'm really concerned. I think you're a little more confused than usual. This is Sally. I'd like you to work with me now. We're going to sit down. I'd like you to drink this glass of water. Isn't it a beautiful day for October? Wow, look at the trees turning color. So it's that kind of conversational orientation, easy to do. Put up the clock, put up the calendar, use a whiteboard. Help the person stay in the here and now. And we also want to make sure that they're getting it. They've got their glasses on so that they can see what's going on around them and don't misunderstand what someone has said or done or is doing because they can't see or hear us. So we want to increase lighting, put on their glasses, make sure their hearing aids are in, and make sure the batteries work too while we're doing that. And then we want to document and communicate across all levels of care in discharge planning and transfers in particular. Please, please do not let the person go out the door knowing they have a delirium without emphasizing that in the handoff to the next level of care. And we also want to reduce the risk that confusion is accepted as being the person's baseline and not addressed. So the person in an acute care setting is assumed to have a dementia and to be permanently cognitively impaired when it's rapid onset and highly reversible. Such a bad thing to let happen. And at the time of admission into post-acute or skilled care or nursing home setting, the person may have a persisting acute confusion. We need to know what it is, that it is an acute confusion, not a persisting, more permanent cognitive impairment like dementia. We also want to reduce risks of misperceptions. There's all kinds of, the person looks at something and doesn't understand what it is. They look in the mirror, they think somebody's there, they see a reflection, they think somebody's outside lurking. So there's all kinds of things that we can do to disguise or remove objects that are misinterpreted. Clutter, pictures, reflections, sounds that are misunderstood. Think carefully about the radio, the television, the address system, people standing at the door. The person doesn't have their hearing aid or glasses in. They hear whispering and they think someone is talking about them. Woohoo, here we go. They're going to be paranoid and suspicious. It's all very, very possible. We want to adjust our approaches, meaning that we want to limit our choices and use a conversational orientation again. And we certainly want to provide guidance to the family, the person who has the delirium, their care partners, and explain that it is a reversible confusion related to their illness, their stress, and it should resolve. So support the person to know what delirium is, monitor the symptoms, and how to get help if it is persisting. We use medication only for the most severe agitation, fear, or psychotic symptoms that pose safety risks to the older adult. There are lots of behaviors that don't interfere with medical treatment and recovery. There are a few that do. And psychotic symptoms or misbeliefs that are troubling to the person may be a candidate for an antipsychotic medication. But the point is, going to medication is like the last thing that we do, not the first thing that we do. And we use medication only on the basis of safety risk and comfort for the person if they have misbeliefs that are really, truly upsetting and troubling to them. And in using medication, we always want to use a low dose short term, and discontinue it as soon as possible, because one of the greatest risks we face is that an antipsychotic medication is started during hospitalization, not discontinued at the time of discharge after the safety risk has passed, and is continued on a longer term basis, posing additional risks for the person due to side effects. So in summary, delirium is a very important form of confusion that's often misunderstood and mistaken for dementia. So we want to start by recognizing changes from baseline function. What can the person do on a good day, on a normal day? And assess changes using a standardized method so that we can quantify what we are seeing and communicate it with our team members in order to identify and treat the underlying healthcare problems. And I do want to say problems because many times it's more than one thing that may be triggering this acute confusion. We want to assure the patient's safety and comfort during the time that they are acutely confused, assist the person and the family to understand that this is a transient condition. It will resolve if, in fact, we can treat the underlying problem and then support the person with ambulation, hydration, nutrition, and safety. So, in short, it has a rapid onset. It will persist until we treat the underlying health condition, and we need to monitor the outcomes to assure that the person recovers fully. Thank you.